I'm Linda Resnik, and I'm very pleased to be moderating this last session of our institute focused on future research directions. This session is central to our mission of CoHSTAR and LeaRRn to stimulate and promote research to improve rehabilitation care. So I'm very pleased that we've assembled a terrific group of panelists for this session. I'd like to introduce them to you. And then each will have a chance to make some brief remarks, followed by open questions and answers. First, I'd like to introduce Dr. Arlene Bierman. She is Chief Strategy Officer of the Agency of Healthcare Research and Quality, or AHRQ. Previously, she was Director of AHRQ's Center for Evidence and Practice Improvement. Dr. Bierman is a general internist, geriatrician, and health services researcher whose work has focused on improving access, quality, and outcomes of care for older adults with chronic illness in disadvantaged populations, and she's published widely in these areas. Dr. Bierman has also developed strategies for using performance measurement as a tool for knowledge translation and conducted research to increase policymakers' uptake of evidence. As a tenured professor, she held appointments in health policy, evaluation and management, public health and medicine, and nursing at the University of Toronto, where she was the inaugural holder of the Ontario Women's Health Council Chair in Women's Health and a senior scientist at the Li-Ka-Shing Knowledge Institute of St. Michael's Hospital. Dr. Bierman has served in many advisory roles, including on the Geriatric Measurement Advisory Panel of the National Committee for Quality Assurance, at the Board of the Health Quality Ontario, and the Institutional Advisory Board of CIHR Institute for Health Services and Policy Research. She received her MD degree from the University of North Carolina School of Medicine in Chapel Hill. She completed fellowships in outcomes research at Dartmouth Medical School and community and preventative medicine at the Mount Sinai School of Medicine. And she's also served as Atlantic Philanthropy's Health and Aging Policy Fellow and American Policy Science Foundation Congressional Fellow. Our next panelist is Dr. Pamela Duncan. Dr. Duncan is professor in the Department of Neurology at Wake Forest University. She is a nationally and internationally renowned expert in health policy, outcomes research, and clinical epidemiology. She joined the Wake Forest faculty in 2011 to develop and evaluate innovative models of care to manage post-acute services for patients with medically and socially complex chronic conditions. She was principal investigator of a PCORI-funded pragmatic trial, which implemented and evaluated an evidence-based comprehensive post-acute stroke services model, or the COMPASS model. This was a cluster randomized trial that included over 40 North Carolina hospitals and over 6,000 patients. The evaluation of this intervention in a pragmatic trial continues to refine the delivery of post-acute stroke care at Wake Forest and may support scalability of applications and models of post-acute care for other health systems. The COMPASS transitional intervention has been expanded to focus on blood pressure control after stroke, and this intervention is being evaluated in another PCORI-funded trial, TEAMS BP. This is the first study of its kind to test two interventions to lower blood pressure in the first 6 months following a stroke. One uses telehealth, individualized care planning, and behavioral health coaching to manage physical activity, medication management, and diet, and the other is an in-person clinic management. Dr. Duncan received her BS degree in physical therapy from Columbia University and a PhD in epidemiology from the University of North Carolina. We have been very fortunate to have Dr. Duncan on the CoHSTAR Advisory Board for the past 8 years, so thank you. Next, I want to introduce Dr. Lyn Turkstra. She is a professor and assistant dean for speech-language pathology in the School of Rehabilitation Science at McMaster University in Hamilton, Ontario, and a faculty in the neuroscience graduate program. Her research focuses on understanding the effects of acquired brain injury on cognition and communication and developing evidence-informed intervention. She has over 130 peer-reviewed publications and is co-author of the text Transforming Cognitive Rehabilitation, with Dr. McKay Solberg and Justine Hamilton. Dr. Turkstra is co-author of the International INCOG Practice Guidelines for Traumatic Brain Injury Rehabilitation. She's consultant to the U.S. Department of Defense and Veterans Health Systems for best practices in TBI management, and co-investigator on clinical trials of cognitive rehabilitation for service members and veterans with mild TBI. Dr. Turkstra completed her PhD and postdoctoral fellowships at the University of Arizona. And finally, we have Dr. Susan Magasi. She is an associate professor and associate head of the Department of Occupational Therapy at the University of Illinois, Chicago. She is passionate about issues of health and participation equity for persons with disabilities and works closely with the disability community using an equity-focused, community-based participatory approach to help understand and break down barriers to primary and cancer care for people with disabilities via peer support and self-management-based interventions. She is increasingly adapting these interventions for remote delivery via smartphone-based apps. Dr. Magasi is deeply committed to mentoring the next generation of disability and occupational therapy researchers with a commitment to students who have been traditionally underrepresented in clinical practice, academia, and research. Her teaching focuses on evidence-based practice, knowledge translation, and qualitative methods. She received her PhD in disability studies at the University of Illinois at Chicago and completed postdoctoral fellowships in outcomes and health services research at the Rehabilitation Institute of Chicago and Northwestern University. Well, those are long introductions, but we really have an illustrious panel. So I'm going to hand this over. I've asked each of the panelists to address our first question sequentially. And we're going to give each 5 minutes or a little bit more perhaps to answer that question, which is, what do you see as the most pressing rehabilitation research priorities to improve care for persons with chronic conditions? So I think we're going to ask you to unmute one at a time. We're going to start with Dr. Bierman, and I'll let you have a chance to respond.
Oh, well, it's such a pleasure to be here. What an outstanding conference. So, I think there were so many lessons here over the last couple of days on what we can do to really transform care for people with chronic conditions and complex needs. And I think that the meeting really started off right in terms of starting with people. What are people's goals? How do we optimize health, functional status, and well-being? And the fact that we need to engage people with chronic conditions and complex needs in their communities right from the beginning in research design. I think the other thing that came out loud and clear from this meeting is how our health system falls so short in achieving these goals, and that we really need transformative, not incremental change. And we need to generate the evidence to support this transformation. And this really entails moving from a disease-specific to person-centered care, from sick care to focus on health and well-being. And, there was recently a great report from the National Academies on whole health. And the VA is a leader in this field in terms of trying to implement whole health in their system, where we really focus on optimizing health and well-being in every person. And we heard a lot about different models of care yesterday. I think the presentations showed it could be done. We need to meet the needs of people with multiple chronic conditions in the context of their lives, aligned with their goals and preferences. And, we know it could be done. People have done these great models, but what the challenges have been is implementing these models in other settings and scaling and spreading them. So upfront, we really need to consider, when we design and test interventions, to design for sustainability and scale and spread. So how can this evidence be adopted in the real world? And the other thing that struck me is the opportunity to learn across models for different conditions. What are the common elements that can be applied to all? And, we really need to learn not only what works in delivering care, but how to make it work, or how to implement all this evidence so it becomes part of routine practice. And one way to do this is by integrating implementation science with quality improvement to learn how to provide high quality care more widely. I love the sessions today on digital solutions. I'm actually working on developing the e-care plan that David Dorr talked about, and he's testing at OHSU. And so digital solutions hold so much promise, but also many challenges and risks. So we really need research on the effectiveness and harms of digital solutions, what to use, when to use it, for whom. And we really need, in addition to that, we need linkages between rehab. We heard a little bit about this yesterday, and primary care, as well as social care and public health, to be able to deliver coordinated, integrated care. And clearly, equity is central, and all research needs to be conducted with an equity lens so that we could improve access, quality, and outcomes for all. And then finally, we really need to do research differently. What we're dealing with is complex interventions in complex systems with complex people with complex needs. And so other approaches that we could use among many include agile implementation, methods from complexity science, mixed methods. And just in summary, there's a lot we know and much we can do to advance this work. Thank you.
Thank you. And then next we'll move to Dr. Duncan.
Well, thank you, Linda. And Dr. Bierman said it so eloquently and so comprehensively. And I just want to applaud this group for the incredibly brilliant presentations that were incorporated here all the way to policy. But how do we do exactly what Dr. Bierman said? And there's no lack of brilliant ideas, great research questions, great technology, but the barriers seem overwhelming. The healthcare system is broken. It is really broken. And those of us who are on not only in the front lines of research, but in the front lines of living in our community, we can tell the specific stories. So I want to, as I've been thinking about these presentations, I want to give you a couple of concrete examples. First of all, we all were brought here to serve the patients in the communities. And somehow we've lost that focus. And what are their needs? And their needs are not being met because there is misalignment of the health systems themselves, and most importantly, the policy and reimbursement issues. And let me give you where we have to go is we have to come front and center with those issues, and we have to bring those questions to the front lines of healthcare. And we have to go to the providers and the patients. It's really the providers and patients now that have to be the influence. So let me just give you an idea built on my years of working in chronic disease and falls and stroke. So you heard in these last presentations, there's total variability among the payers in authorizations for care. There's no transparency in that. The patients don't know, the providers don't know, and they don't have the ability to even understand what's going on. And right now I'm under confidential disclosure, but we as American Heart Association, and I'm a partnership in this policy paper is, well, what do we need to do for research? We need to do practical things. We need to understand and bring to CMS with transparency as a research question. We have to bring with transparency, what are these different authorization processes, whether it be Medicaid, Medicare Advantage, or Medicare fee-for-service. The great advantage of this type of research is establish the knowledge about it. There's tremendous variability, and then take advantage of the available data to see how that variation influences outcome. Does your access to care really affect your outcome? But also, money drives everything. Money drives everything. And right now, there are a number of initiatives going on in the real world that we're not even aware of as researchers. The University of Virginia, a colleague of mine, Chad Aldridge, for example, has been working with the stroke registry and health system data there and demonstrating that, for example, in that state, there's such a delay to get access to stroke rehab authorization that they've demonstrated that that increases the length of stay in the hospital, and 1.5 days, length of stay days, actually will pay for 1 week of inpatient rehab. So we have to bring economic and return on investment models to this. I would say another concrete example, everywhere I go, American Heart Association major meetings, the physical therapy, everybody's in there with their gadgets, with their remote monitoring, with their telehealth proposals. But let me give you a concrete example of rehab. The big focus area that they are targeting right now is cardiac rehab. Because in real world, the uptake of cardiac rehab, which is reimbursed with a very specific evidence-based model of how many times a week you should get it, the uptake is 12%. And of those 12%, only 33% stay with the program. So we need to take those programs, examples of those, and say, well, what are the barriers? What are the patient level barriers, the transportation issue barriers, the cultural barriers, the economic barriers that is driving that limited input? So that's another concrete example of where we need to go. But I'm afraid, and I want to make this comment, you just heard about this brilliant CP Net Research Network, right? You know what? We need a health services research network of the brilliant minds, some represented in these presentations, is to figure out what are the most impactful and policy relevant issues that we can change to increase access to all for healthcare. Adding more technology is not going to work, because guess what the failure rate is in technology as we know it today, 60%. Well, all of us in chronic care know, including me, I don't have a chronic care condition, but I'm getting elderly. It takes a lot of skill to manage technology. Do you have the usability to use it? Do you have the knowledge to use it? And can you afford it? Right. So we've got to bring networks together. Certainly the leader in this, and in deference to Dr. Bierman, has been the health AHRQ, right? But we really need to be more resources in that realm, and we can't do it incrementally. And we got to take the pressing issues.
Thank you so much. Now we'll move to Dr. Magasi.
Thank you. I appreciate the systems level thinking and recognition that everybody has been focusing on. For my comments, I wanted to drill back down to the consumer and the importance of meaningful consumer engagement in the rehab research process, from bench to bedside to community to policy and pavement. You know, we're dovetailing with his historical moment where we're really starting, hopefully, and arguably, to pay attention to some of the impact of structural barriers like racism, sexism, ableism on people's experience, opportunities, and outcomes, and especially when we layer in some of those issues around social determinants of health that were discussed earlier. And we know that those have a profound impact on how services are organized and how research is conducted. So this should challenge us as a healthcare community and as a research community to think really critically and carefully about how we're engaging people with lived experiences. And I'd actually like to use the term disability because I think there's power in that word. And we need to reflect deeply on what our implicit biases are about who can and cannot contribute to research and clinical enterprises. And then we have to work really hard as a community to dismantle some of those biases. The inclusion of people with disabilities and lived experiences is just a starting point, but it's not enough. We also have to challenge ourselves to diversify the range of people who are included in the process. We have to question if we are constantly tapping the usual suspects, the people who become almost institutionalized into the role of the patient expert, but may not fully capture the range and diversity of the consumer group. what voices and perspectives remain unheard and underrepresented because they are hard to reach or are time and resource intensive to gather. We can draw from some of the principles of community engaged participatory research to help ensure that their needs and priorities are reflected in what we do. We need to challenge and continue to challenge the narrow inclusion criteria that have historically excluded people with disabilities from research, and especially people with those complex co-occurring disabilities and comorbidities. I would personally love to see funding agencies start to acknowledge and support the costs that are required to do this kind of community engaged work, to partner with language minorities, to partner with people with communication challenges, so that those costs don't come off the science and the support of engagement of community members, but can be built in as necessary infrastructure. I think we also need to challenge ourselves as researchers and healthcare providers, because we're trained to hone and therefore value certain ways of knowing, doing, and communicating. But we need to be cognizant of the fact that those ways of knowing are not absolute. And we must constantly interrogate those power dynamics within our research processes and healthcare systems. Often when we talk about ways to support people with lived experiences, involvement in research, we focus on building their knowledge, skills, and abilities to sort of meet us where we are as healthcare providers and researchers. And I think it's important that we make sure that we are not blunting then the insights and the expertise that come when people bring their lived experiences, their values, their cultures, their different ways of knowing to the enterprise. And those are some of the issues that will help with, hopefully, some of those scalability, sustainability, and transferability of programs to diverse communities. And then I think finally we need to break down the dichotomy between people with lived experiences and who we envision as healthcare providers and researchers. So we need to invest significantly in creating that pipeline of people with lived experience to not only serve as the patient expert, but to also be the people who are the career scientists, who are the policymakers, who are making payment decisions. So an investment in the infrastructure. And then finally, I just wanted to point to a resource. It's a paper from 2014 by Masuda and colleagues out of Canada, that they created a matrix that's called an equity-focused knowledge translation, and it challenges research collaboratives and healthcare systems to engage in critical inquiry and reflective practices to identify what voices are present, what knowledges are valued, and what opportunities we can identify and potentially miss when we're not valuing different partners. Thanks.
Thank you. And now we'll turn to Dr. Turkstra. And if you want to share your screen, I think you should be able to.
Thank you. I will share my screen in a minute. Thank you so much for including me, and really for a pretty amazing conference and group of presentations. So it might not surprise all of you being in rehabilitation that as a speech language pathologist, I have slides. Also that my speech rate is so fast that it's a working memory load. So slides will help. I wanted to share an example of what I think is a really big research need. I had sort of the opposite trajectory of Dr. Bierman in being born here in Canada and then working my whole life in the US and then coming back to Canada a few years ago. And I thought things would be different here, but it's really a similar problem. I want to use brain injury rehabilitation as an example. So I think that what I see as a major need for research is for us to be able to collect data and talk to each other across the continuum of all the touch points in rehabilitation where patients are. And this is sort of the typical old model of rehabilitation where someone has a brain injury, they go through all their in early stages of recovery, and then they have rehabilitation for chronic cognitive impairments. And, you know, that was great when people had long lengths of stay in the hospital and could get rehabilitation that was related to their lives. But now the average length of stay is about 14 days. And so this is what it looks like now. So people are getting front-loaded rehabilitation during their inpatient stay, and some of them are never getting anything after that. I learned an expression on sabbatical in the South, discharged to the couch, where people come out of the hospital and go home and never have anything else. And so Audrey Holland, who is just an incredible pioneer in my field, published a paper, gosh, now I realize 22 years ago, talking about how we should rethink what we do during rehabilitation and when we do it, which is now almost entirely driven by money. So it's driven by, you know, who's going to pay and when they're going to pay. And I wrote a version of that for cognitive rehabilitation 10 years ago. It was very controversial at the time to say, should we even be doing cognitive rehabilitation on inpatients? I mean, it doesn't make sense to spend that much time and money when people are changing every single day and they don't even really know what their challenges are going to be like until they get home. And as it's possible to make these changes. So we did, I'm a visiting scholar at Moss Rehab in Philadelphia, and we actually came up with a protocol to change inpatient rehabilitation for patients who are in post-traumatic amnesia. And it's part of a traumatic brain injury model system. So it can be rolled out to other centers nationally. Just a small effort by a really dedicated team, but it was possible to make changes. And so I just want to pitch for what I consider to be the dream for me, for at least for the patients I see. And that is a different version of the episodes of care model that Megan O'Connell talked about. And I do wish she was here because I think CMS is such a big partner in this. I wish that people could get the rehabilitation that they need when they need it, and not just when the system supports it, and not just when payment dictates it, or when scheduling software tells you have to have, you know, OT at 7:30 in the morning, when maybe you're not a person who wants OT at 7:30 in the morning. So I wish we could have these episodes of care, but how would we know it would work? Well, it takes research funding that addresses all the stakeholders. And that's where I see the really big gap. Many years ago, CMS had a research project where they would pair with a rehab facility to test out an alternative model of care that was beyond a single treatment. It was a whole trajectory that was an alternative. And I've never seen it come out of CMS again. But I think this partnership between people with research money and hospitals and universities is what we need. And those payers are lots of people. That's where I think we're not really communicating very well. So CMS is a big payer, but so is Social Security Administration if they're having to pay for people who can't work. Small business, large business. We did a really depressing study with very depressing findings of insurance companies in Ontario and the experience people were having with insurance companies, which is just a nightmare. And so even insurers need to be on board. So I feel like the research that we need is something that I thought the Affordable Care Act was going to give us, and I thought that Ontario's single payer system would give us, which is a way to look at a person's trajectory across their whole care and figure out where we should be spending what kind of money. So I looked up a graphic for integration and got this, which serves me right for looking for a graphic for integration. But that's where I would like to see things go.
Wow. Well, thank you all for those great kickoff comments for the rest of this conversation. I think you've raised some really crucial points. Several of you have really talked about the need for research to drive payment policy. And so I want to open this up for further discussion, building on your comments that we've just heard. And as Dr. Duncan mentioned, what type of research should we as a research community be producing that can help to drive change in payment policy? So you can raise your
Can I
hand.
just make one comment about what Lyn said, and maybe
Sure.
dovetailing on what Susan and Arlene. So the level of research that's required to do this does not need to be incremental and one-off. If we really put our heads together in these collaborative networks with funding agencies and bring CMS to the table. As Lyn has pointed out, there is one source of a lot of information that we don't have information to, but it's the payer information. And they are in the United States, I can't speak to Canada, but they're using it not for us, but against us. And so there needs to be absolutely a requirement from CMS and from the funding agencies like AHRQ or PCORI or whatever, that we have access to that information. If you've got chronic conditions in this country and you are insured, right, like with the major Medicaid, Medicare, so forth, and even the, the information's there, but we don't have access to it. But guess what? In the US right now, CMS, they're under investigation because they're coming into homes with their representatives, the United Healthcare and Aetna, and they are asking to get more information to upcode their chronicity, but they're not providing more services, right? So these are the real challenges that we're facing, and having access, as Lyn pointed out, in so many ways is absolutely critical in being an advocate. That's what's missing in our networks, are bringing the responsible parties to the table to collectively contribute to the knowledge that we need.
Would anyone like to build on that? Or you'll need to unmute, please.
I totally agree. And I think also looking for opportunities to make alliances across different, because these problems with rehab are the same problems, with geriatrics and with care for kids with complex needs. And I think trying to figure out how do we share, both the research and the evidence across all these different groups, and how do we use all this evidence to inform policy? So I think the more we can, because I hear the same issues over and over again in multiple contexts, and you're absolutely right, our system is broken. And, having practiced medicine both in the US and Canada, what I learned was, although our systems were different at the point of care, the challenges are the same. And really taking, opportunities for more cross-border learnings, because each system has some things that work and some things that don't, and can we share?
So maybe we can go back to my question then about what we can do as a research community. I'm hearing the need to get access to payment data. I'm feeling very fortunate to also be a VA researcher where we have payment data. But what kind of research can we do to drive changes in payment policy?
Well, Linda, I hate to say it, it's research that will influence economics. And economics is not just about the money, but the economics of health, right? And that sounds pretty lofty, but we've got a lot of research, we've got a lot of efforts, but we've got to build those partnerships. And I will also, I have a conflict of interest, but I'm going to say it anyway and declare it, is that what LeaRRn has done and what Linda Resnik and the group has done with actually funding from the Foundation Physical Therapy, it's just amazing what this group is doing. I've been on the advisory board and with CoHSTAR, and you have got, actually, Linda, and I need to give you all the credit, not all the credit, but a lot of the credit in terms of your visionary leadership. But you've been able to do this, and now the challenge that you have is, well, where do we go for funding to get this network, right? This network to continue this. It is true, Dr. Bierman, that it's not, we shouldn't just call it rehab. It is individuals, I'm geriatric research. I am geriatric, I'm a geriatric researcher too. I think we have to be able to scale, and Linda didn't ask me to say this or whatever, but I feel it passionately. is how do we take this and build and create from this experience networks to bring all of these in. You've done it in programming, you've done it in career development, you've gotten some important, but to sustain it, there's not a funding mechanism for networks to do this.
I think.
I'll just say thank you. Thank you for your.
Well, I think we have a lot of education to do. I think there's a time, this is a time to do it. I don't think there's a lot of understanding about what health services research is, right? And it's easy to, advocate, like yesterday we heard about autism, autism, Parkinson's disease. It's easy to go in and say, make a case for specific diseases. There's no constituency for whole person care or whole health or, redesigning the health system. But I think that COVID really brought out, made more people aware of how the system is broken, that, we know, but not everybody knew. And I think, at ARC, what we talk about is the science of care. And what we have to educate people, like there's a biomedical science and clinical science, but there's also the science of how do we inform, care, and how do we improve it? And I think we need to let people know that that's a good investment, because there's so much opportunity, to reduce the waste in the system, to reduce, costly adverse outcomes. We pay for things when things go bad, but not beforehand. So I do think, I don't have any magic answers, but I think, that's the direction that we all need to move.
I just,
Dr.
sorry, Linda.
Go ahead,
I'm
Dr.
sorry.
Turkstra.
I've spoken. But you know who does care about care? The elderly, those people who've had stroke. As Susan said, all of us, and I'm in that community, everybody is screaming about the care they're receiving. Mm-hmm. And it is a tipping point. And I think agencies like AHRQ and other initiatives, we have to be able to communicate effectively about the care. But I haven't met any of my constituents or my professional colleagues who aren't concerned about the care. So we got to figure out how to message about that with the input. And honestly, I always believe a picture is worth 1,000 words. So a case examples of the failure of care for all people.
So I just want to pivot and take off of that comment, and as what you spoke about, Dr. Magasi, about partnering with persons with disability lived experiences. What ways can we as researchers help better partner? And, what are some of the concrete ways that we can improve engagement?
Well, I think it requires a deep commitment that it is an important component of the research and discovery process. The recognition of the relevance and the increased relevance that comes from it, and that it's a routine part of our training in terms of what we do. And I was thinking about that with the payment question too, in terms of like where the field needs to be and where we are training our students, our community members. We don't really talk about the financial aspects of care. I know in engineering programs, you have to take a certain number of economics courses as part of a bachelor's in engineering program. We don't do that in healthcare. You maybe take a payment course, but it's more about how do I get reimbursed for my services rather than understanding sort of the economics of it. So I think at some point we do need to look back at how we are training clinicians, how we are training researchers, how we are inviting people with lived experiences into our professions by making it a welcome and inclusive space. There's been tremendous success in pipeline programs for underrepresented minority students. There has been much less investment in pipeline training programs for students with disabilities. the structural ableism that continues to permeate healthcare, education, employment, it all impacts some of this work. But not to be too lofty, then, it's a radical reform of all of these systems. But then concretely, we need to be able to communicate the value and meaningful value of community engagement and community participation in research, because I think it's easy to tip one's hat to doing community engagement by forming a community advisory board, or by having, what can sometimes be sort of token representation in our teams. So I think what we need to do is have a culture shift so we really value those insights. Between sessions, I'm going to out myself a little bit. I wrote to Lisa Juckett in the chat and said, "Oh my goodness, I'm out of my depth in this discussion of health informatics and payment and policy." And then I flipped it around and thought, oh gosh, how must our consumers feel sometimes when they're invited to the table to be part of these conversations? So what can we do to help build sort of their capacity, but also to meet people where they are, so that we are able to get input from people, with a whole variety of perspectives. And you don't have to be a super communicator or a, healthcare expert in order to have a seat at the table.
And there is a comment in the Q&A, I think that from one of the attendees that says, "Those with disabilities are frequently so afraid to disclose. I know this personally, and that keeps teams unaware that they actually do have someone who represents the condition." And I assume that means, and presumably is like interested in engaging in research. So I think that speaks to that. Now I see some other questions in the Q&A. I know we have lots that we can discuss. There is a question or a comment that says, "To be honest, I experienced..." Yes.
Oh, I'm sorry, Linda. I don't mean to interrupt you, but I have a resource just following up on Susan's comments. I wonder, I can send it to you in the
chat,
because
for
I
everyone.
sent it to you in the chat. Yeah,
that's
for everyone. So our long COVID research is with the Patient-Led Research Collaborative, which is a group of scholars and scientists with, advanced degrees and incredible skills who are driving the research agenda in long COVID. And they've created a scorecard for community engagement. They just shared it a couple of weeks ago. And I think that's why I put the link in. I think if people are interested in looking at how well they're actually working with people with lived experience, it's really a great concrete tool.
Great. So that will be in the chat, and we'll have it to share. So the comment I was going to now is about the competition regarding research ideas and sharing data and ideas. And here we're talking about how we need partnerships and networks. But I think this comment is true for many of us in research, is that there's such competition for funding and ideas. So being afraid to share ideas and not lose your idea to a different grant, and having someone else come up with your competing against you and losing a grant. So how do we balance this need to network and share and collaborate with our own careers, and the fact that it's such a competitive realm?
So go ahead, Dr. Bierman.
Oh, that is such an important question. And I think we need to realign our academic incentives, to reward collaboration and partnership, but also, and to stop being afraid of, because actually there's richness in sharing, in getting, because these are complicated, complex problems. And if you have, like ARC, we often fund learning communities. We're doing something now about urinary incontinence in primary care. And initially, grantees are afraid to share, and then they realize they could do better if they learn from each other, because, different people have different things solved. I'm working on the e-care plan, which is all open source, public domain. This is a hard thing to do. And if other people want to take it and build on it, I am happy. So I think we need to be able to acknowledge people's contributions, acknowledge their ideas. And this is not going to work unless people figure out ways to both like advance their careers and advance their ideas and at the same time be collaborative. We can't do this unless people are working together.
Well, that question is disappointing to me because many of you know I've had a 50-year career in this and $100 million+ of funding and whatever. And at the end of the day, when you get to my point in my career, and I never took that attitude. I never got anywhere without the team.
Mm-hmm.
And your best, and if you go look and listen, I do a lot of different listening, but go look and listen to some of the greatest innovators in the world who have become very rich, Warren Buffett, for example, or other people. And you know what they always say with great humbleness? I didn't do this. I wasn't even the brightest light in the chandelier. But I knew how to pull the lights together. And clearly, we have to go back to our soul and our spirit of why we get up every day. It isn't about us. And actually, I think tenure probably now is pretty worthless, if you want to know the truth. And we have to be able to think about what is the purpose of what we do. And you will never accomplish it alone. And so why not get in the room with the brightest minds and work collaboratively and collectively? Now, academic institutions don't have it, but who gives a damn about them anymore? It's about what you can do to make a difference. And the funding agencies now are recognizing now they don't call them co-PIs, what they multiple PIs or whatever. And as a young investigator, let me assure you, the best thing that you can do in your life is to find the community and the network to work with and work with them and become part of that community. And one day you'll be a multiple PI, right? I'm a physical therapist. I'm proud of that. People sometimes call me a former physical therapist, right, Linda? I brought a unique set of skills to neurologists and geriatricians, and it took that integrated community. I didn't wear my profession on my sleeve, and I sure is dumber today than I was when I started because it's even more difficult. And there has to be a humbleness about this. And maybe this sounds too preachy, but I do believe it. Did you make a difference in your career? Why am I still working? And I am retiring June 3rd, but not really retiring. Why did we do it? We did it to make an impact. And we did it to make an impact. Not one of us has a solution to this.
I want to second that. You know, I'm a recovering academic, and I always was open and shared, and I always thought it served me well too. And also,
Yes.
you know, was very well funded and, you know, lots of publications. I think that the fear, I think it hurts people more than it helps people, that fear of not collaborating.
That's right. Thank you.
I do want to make sure to get to Dr. Lewis Case's comment. He specifically called out a thank you to Dr. Bierman for your remarks and pointing out some of the macro dilemmas facing the U.S. healthcare system. You know, I think as I have others, Arnold Rallman, former director of New England Journal of Medicine, termed the healthcare system the medical industrial complex. So he asks, given the fragmentation of our healthcare system, how does one begin to assemble a new model that brings together the many voices within our healthcare system? Is there a silver bullet that one can turn to? This is a textbook answer. This is more than
I wish there, thanks Lou for that. You know, I wish there was a silver bullet, but I think the silver bullet is everybody on the screen and everybody who's listening today that, you know, when I, you know, as a researcher, I always felt like I'm contributing. I'm part of a community that's building this evidence to make change. And I've seen things happen. I was doing equity work 30 years ago when people said, why are you doing that? Nobody's interested. And it's a sort of follow our passion. And now you can't do anything without mentioning equity. So I've seen things change over time. But I think the more that we can work together, collaborate, accelerate evidence, have learning communities, the more likely we are to do this. And we do need to learn how to message, and that's not my forte, but I think we need to learn how to communicate it beyond ourselves and why this is so important, and also the potential of all this work.
So Dr. Turkstra, you highlighted on your slides the challenges that we have with continuity of care and transitions across settings. And I know we heard some talks earlier about the CP network and the registries, and we're talking about networks. So my question to all of you is, how can we build the infrastructure? And I know a lot of it is data infrastructure and collaborations, but how can we build the infrastructure to perform the kinds of research studies that are needed to follow people across transitions of care into different settings, and sometimes into different systems? How can we do that? What are your thoughts? Who would like to take that?
I actually, I'm happy to take a stab at that. I was recently at a fantastic conference in Atlanta called Think Big. That was a meeting to bring together stakeholders who would typically not talk to each other. And I feel like this kind of a meeting, so that we, I was taking frantic notes during Megan's presentation and, other things going on this afternoon. So I think that's one way that we can do it, is just get in a room, virtual or otherwise, and actually talk to each other. Our conference was around vulnerable populations, especially intimate partner violence and youth in the criminal justice system. So we had people from shelters, who were there, so that we could talk about, raising awareness about brain injury in the intimate partner violence shelter world. And we learned so much from each other. So I think just having a meeting where we cross sectors, which doesn't always happen, right? Often it's like within rehab or within government or within policy. So I think that would be a great way.
Yeah, we've certainly noticed, that many of our interesting policy conversations have happened individually within profession-specific conferences, like the combined sections meeting or the occupational therapy, annual meeting. And excuse me if I don't have the title of the meeting correct, but we've been very siloed. So it's been a real pleasure to see these things come together, so we can see some of the commonalities. Because behind the scenes, there is some advocacy out there, quite a bit that happens jointly, but it is unusual to get everyone together in a room to consider some of these issues together. Other thoughts about infrastructure development?
Linda, I think I'm sorry, Susan.
Go ahead. No, go ahead, Pam. I'll go after you.
I think we learned a lot from COVID. We were able to actually learn more from the Israeli and the UK healthcare system than we could our own, because we didn't have one payer. But without any political overtones at all, I don't mean this, it's a very bipartisan comment. Well, the catastrophe in that is our failure to know how to communicate, and to be able to communicate in simplistic terms what we were talking about. We had a lot of influential variety of talking heads, but the CDC, especially, we've got to figure out how to engage and get the perspective. And it was very interesting as we heard the long COVID experience. Most of those patients were dismissed, right? They were totally dismissed and as they started presenting their symptoms. So maybe I'm taking us down the wrong path, but in this, and maybe I'm picking up on what Lyn said, but if we're going to build the successful network, it's not just the clinical providers, it's certainly the patients who care, but it's also, we've got to figure out how we identify in academics the absolute perverse incentives for us to do things like this, decide to overcome them. But most importantly, we've got to figure out how to communicate and when to communicate, right? If I go back to the hat I wear and am angry about it today's, is the limitation of patients' knowledge. I've had firsthand family experience, is people died because they didn't understand. what services were available and where they went. So we've also got to determine when is the point to communicate. People find me on the internet all the time. I could spend every day answering all those emails about, please tell me where my mother should go and how do I navigate this system. And they're vulnerable, right? The patients in that case are not the ones, it's the caregivers. We forget them as well. So communication has got to be part of that constituency and know how to communicate. I just know how to talk Southern, right? And but I do know how to communicate with people from multiple perspectives, right?
Would you like to add to that?
I was just going to acknowledge and think that we need to acknowledge that the fragmentation of the healthcare system is intentional. It's not an accident. It's not because we don't know, but it's the way things are structured. It is that medical industrial complex. There are financial incentives. There's the debate among climate scientists about what is their role in doing scholarship and doing advocacy. So I think it goes back to these ideas of messaging that other people spoke about. How do we message the science to policymakers? How do we effect change? How do we bring some of these issues even more to the forefront so people have the willingness and the commitment to affect change, because it's going to be a radical reformation, whether it's in the United States or whether it's in Canada. There are problems that are going to take a lot of collaborative work to fix, and there's opportunities to inform that dialogue through the work that we do, and through some of those cross-cutting relationships that we can build. I love this think big idea, because that's what it's going to take.
Well, we just have a couple more minutes before we're going to wrap this session, and I want to give you the opportunity, if you'd like to make any reflection on the comments and the discussion we've had here, or any of the other portions of the Institute that you've been able to attend, with just a couple minutes to wrap up.
Don't give up.
Don't give up.
This is not the time to give up. It really isn't. Just reflecting on a personal story is, I went to my grandniece's graduation over the weekend, and she was the most quiet, unassuming person I've ever met in my life. And she was a salutatorian of 600 class and gave the most incredible speech. And we never know what to expect. But her speech was really what we're talking about today. And she's 18 years old going into college. We are a patchwork, right? And we've got to find the thread that binds, and we have to continue to pursue this. And I think now I am confident that I could have gotten much better health care 50 years ago if obviously some of the new technology wasn't there, but if I needed chronic care management, I had a primary care provider who knew me in the community, knew my family, and knew what our needs were. But now, all the technology and sources, we can't, just please don't give up.
Would anyone else like to chime in before we wrap? Well, I think that's a great message for all of us. And I really want to thank you so much for participating in this research directions panel, for your thoughts and your feedback and suggestions for our future directions. So I think now, before we bring the Institute to a close, I want to remind attendees that we have an evaluation, that we like to get feedback on our content. I know there's a link posted in the chat. If you could please click the link and fill out the evaluation. We really hope that you've enjoyed the Institute and that you'll join LeaRRn for our next exciting event, which is our third annual Health Systems Leadership Forum. Our previous forums were limited to LeaRRn investigators and health system partners, and this year's event, which will happen in September, will be the first to be open to a broader audience. The first day includes a keynote address by Rob Srivastava from Intermountain Health and sessions on developing infrastructure for learning health systems research and transforming data to knowledge. And the second day includes a keynote address by Elizabeth Shankman of the University of Florida with sessions on decision support tools and future directions and addressing the challenges. So I think that'll be a really interesting discussion. You can register now for each day using the link in the chat. And then we have already scheduled our webinar series for the fall. We have a really good lineup of fall speakers. We have Gretchen Piat on breaking down learning health system silos, Stephen Hunter talking about team-based clinical research within a learning health system, Kristen Rosengren talking about strategic communication strategies for research impact, and Pimjai Sudaswad on knowledge translation, the what, why, and how. And then lastly, I want to let you know that MR3, which LeaRRn is a part of, is having their annual scientific retreat, which is called Moving from Potential to Real Impact, Engaging with a Broader Community to Improve Translation of Rehabilitation Research Innovations. So I think we see a theme in all of this continuity to further our learning in these topic areas and develop our strength. You can register for that retreat in the link in the chat. So with that, I really want to thank you for your attendance and for all your great participation, and look forward to seeing you at our future events. Thank you so much.